We started off with the adults, and then Catherine will speak for about 45 minutes, the implication of this. Is this mic on? Yeah, with paediatrics. I always start my presentations with a real-life case, and this patient came into the emergency department at the Royal Melbourne late October last year, and she was a young 24-year-old woman with chronic anorexia nervosa. And I've put a slide on the right there, a picture of what's the inherent problem of a young thin girl looking in a mirror and what she sees. And I've been to quite a few talks on anorexia nervosa, and many of the speakers have a similar slide. But she was very unwell when she came to the emergency department. She collapsed at home. She had a pulse rate of 38. She had a blood sugar of 2. She was hypothermic with a temperature of 37 and a low blood pressure. So as soon as we're rung about a patient like this, we know that this patient is in high risk of dying. An examination, her BMI was 10.3 and she was drowsy and semi-rousable. The emergency team in the Royal Melbourne gave her some intravenous fluids. They thought she was a bit dehydrated. They gave her some atropine, which is a drug to increase heart rate. They gave her a dose of IV glucose because of a low blood sugar and some oral glucose. And very importantly, they gave her thiamine. A lot of doctors don't know that if you give someone with borderline thiamine deficiency oral glucose, you can create acute beriberi because thiamine is essential in the Krebs cycle, and so it's very dangerous to give someone glucose without giving them supplemental thiamine. And people with beriberi can go into acute left ventricular failure and die. She had very deranged biochemistry, and this is one of the most deranged biochemistries I've seen in severe starvation. She had what we call pancytopenia. She was anemic, lowish white cell count, low platelet count, a little bit macrocytic on the blood film, probably due to some coexistent folate and B12 deficiency. Hyponatremia is not an uncommon thing we see in severe anorexia nervosa. It can be due to dehydration, or occasionally it can be due to water overload. Some of these patients drink a lot of water, and I've seen people come in with sodiums of as low as 110 with water overload in anorexia. Her serum magnesium and corrected calcium were okay, and serum phosphate. And that's very important to recognise. Even though someone can be so depleted, the circulating levels of electrolytes initially can be normal. We're going to talk about the problems of refeeding these people because there can be a sudden shift in serum electrolytes with refeeding. The other thing that was quite disturbing in this young girl was an acute hepatitis with transaminase 1,690. For those that are not familiar with the normal units, these should be less than 50, both the ALT and the AST. So markedly elevated transaminitis consistent with an acute hepatitis. She also had markedly elevated muscle enzymes consistent with rhabdomyolysis. Thyroid was normal. Any patient who comes in with a low temperature, we think of underactive thyroid. She wasn't pregnant. She hadn't taken an overdose of paracetamol. And her ECG was very concerning that she had a bradycardia of 40 beats per minute with a prolonged, what we call QT interval, which is something that concerns us because it's a precursor for what we call torsade or polyphasic ventricular tachycardia. And one of the mechanisms of death in anorexia nervosa is ventricular arrhythmias. So the conclusion was we thought she might have what we call ischemic hepatitis secondary to low blood pressure. That's a well-recognised entity. If the systolic pressure is less than 80, you can get lack of blood flow to the liver. But also importantly, there's a condition called starvation hepatitis. And that's something we see in rapid weight reduction. You get fatty infiltration of the liver with steatohepatitis. Very importantly, as you're aware, glycogen is the storage of carbohydrate in the liver. That's why marathon runners carbohydrate load before they run to increase liver glycogen. And glycogen lasts you as a glucose source when you run for about 40 minutes. And then if you've used up all your liver glycogen, then you've got to mobilise muscle protein for gluconeogenesis. And that's why these people waste muscle. It's because they're mobilising particularly glutamine, alanine and glycine from their skeletal muscle, take it to the liver and convert it to glucose. If you're not eating enough glucose, you mobilise muscle. Very importantly, our conclusion was both the bradycardia and the hypoglycemia impinged on her conscious state. She had rhabdomyolysis and severe malnutrition secondary to anorexia nervosa. I'm not going to bore you with detailed biochemistry, but there's just a few things you need to know about as far as the risks of dying with starvation. And one is the development of ketosis, and that's why we recommend that you test the urine for ketone bodies in someone with severe malnutrition. When I worked in America, there was a fad of having all these weight loss clinics where people would come in and go on these very restricted diets, 800 calories for 2 weeks, and you'd pay $10,000 to go to one of these clinics. And people died of metabolic acidosis because the people in these weight loss clinics weren't measuring daily urinary ketones. And then they introduced a law in America saying if you go to one of these inpatient weight loss clinics, you have to measure the ketone bodies in the urine. And they legislated you couldn't put someone under 900 kilocalorie total calories per day diet for. These are obese people trying to lose weight. So I just stress the point of measuring ketosis. Experienced clinicians can smell ketotic breath, particularly in diabetics, ketoacidosis. The loss of mean body mass affects all major organs, and the one that's critical is clearly the heart, and cardiac output falls with loss of energy source in the myocardium, but also the correctable deficiency of thiamine deficiency. So I place all these people on high-dose thiamine, like we place alcoholics on high-dose thiamine, to prevent acute beriberi. And you can measure serum vitamin B1, thiamine, or red cell transketolase level to document thiamine deficiency. There's also concern about starvation on the gastrointestinal tract. The enterocyte atrophies, and there's this concept of increased infection rate due to translocation of gut bacteria into the systemic circulation. And the commonest cause of death in severe protein-calorie malnutrition in Africa is actually infection. That's what people die of. They get pneumonia or they get septicemia. There's two mechanisms of that. One is with malnutrition, you get suppression of your immunoglobulins, particularly IgA, but certainly translocation of bacteria. Undernutrition can affect the bone marrow, and as we saw in this case, anemia, low platelets, low white cells. And there's intracellular loss of potassium and phosphate. 98% of body potassium and phosphate is intracellular. Now, as you saw in this patient, the serum potassium and phosphate were normal. The body preserves the serum circulating levels despite severe intracellular depletion. There's crenation of cells and depletion of intracellular water. There's lots of micronutrient deficiencies, and we give these patients zinc, we give them multi-B to supply other, particularly vitamin B2 and B6 deficiencies. Catherine's going to talk about the effect on the pituitary gland, particularly in young children who get amenorrhea and altered prolactin secretion. But all the hormones like thyroid hormones, insulin secretion, growth hormone release are all reduced. And this reduces your metabolic rate by 20 to 30%. So consequently, the body becomes bradycardic, hypothermic, and hypotensive. And there's a list of the really important clinical signs to look for in your patient with anorexia nervosa, particularly with a body mass index less than 15, that can result in really dire consequences if they're not recognised. When we talk about, I think a lot of young doctors and the nursing staff now are familiar with this condition called the re-feeding syndrome, and certainly all the dietitians, I've lectured on this in courses at Deakin, are familiar. And the sort of patients we, as gastroenterologists, are aware of is clearly anorexia nervosa, classical malnutrition, kwashiorkor and marasmus. Unfortunately, it occasionally occurs in surgical wards now. We see patients just on saline drips for 10 to 14 days, and they are at high risk of refeeding syndrome, alcoholics who get all their calories from alcohol and not proper balanced diet. One of the things that seems a little paradoxical, people with morbid obesity can get malnutrition. So I now define malnutrition not based on body mass, but on body function. So an obese person with a BMI of 35, if they got a bowel obstruction, had vomiting for 3 months, they could get significant functional malnutrition even though their BMI is still above 25. And that's a really important thing that dietitians now understand, that cell membrane dysfunction occurs with malnutrition even if you're obese. Prolonged fasting, about once a year we get asked for an opinion on a hunger striker, usually Christine sitting on the steps of Parliament House, or I was involved in studying the people in the Maze prison in Ireland back in the early 80s who starved themselves to death, and we actually got the prison guards when they died to weigh them so we can work out how much weight you lose before you die. I read Catherine's slides last night, and she refers to this document, which is, I think, a brilliant document put out by the College of Psychiatrists in the UK called the Marzipan, Management of Really Sick Patients with Anorexia Nervosa. And just to summarise the executive summary of the key recommendations, that we now have to be aware and educate our colleagues to safely refeed these patients, avoid the refeeding syndrome caused by too rapid refeeding, but equally important, avoid underfeeding them. Don't be too cautious that you're giving them 10 kilocalories per kilogram sort of for 2 weeks because you're scared of what I'm about to tell you about. And I'll give you the protocol that both Marzipan and we follow. This is a multidisciplinary approach where we involve all the team of psychiatric staff, looking at behavioural problems. Occasionally patients need to be treated under compulsion, as you're aware. Sometimes patients have to be either physically or chemically restrained, and either for nasogastric feeding. Over the years, I think I've TPN'd about 3 patients with severe anorexia who we couldn't restrain pulling out their tube. Got to manage any family concerns. And in Victoria, there are some special eating disorder units like we've got at the Royal Melbourne Hospital. So, risk assessment, this is important. We sort of have some fairly strict guidelines of what puts you at risk in the definition of anorexia nervosa, unlike bulimia, with a BMI less than 17.5, high risk less than 13. Remember, our patient who came in was 10.5, I think, and medium risk there. Look for blood pressure, pulse rate, muscle power, which reflects muscle wasting, and there's a special sit-up, squat, stand test to see if patients can perform that manoeuvre. As you're aware, a lot of people with anorexia nervosa over-exercise. They're running around the streets with BMIs of 17 and running marathons and all that sort of thing. But once they start to get physical weakness, you know they're in the high-risk area where their muscles are so depleted of particularly glutamine. Do your blood tests, look for that low sodium, suspect water loading. Just an anecdotal story, the other severe hyponatremia we see are all these people who carry water bottles and drink, and they're drinking Gatorade and things like that. Gatorade is the most dangerous drink that you could ever drink in a marathon or a thing, because all it is sugar and water. The salt concentration is 14 millimoles per litre. We had 2 young athletes doing a 5k run who drank 5 or 6 of those Gatorades, came in fitting with serum sodiums of 115. It is not an oral rehydration solution, although it's marketed as such. As you're aware, Gastrolite, which has got about 35 millimoles of sodium, we use the St Mark's solution, which has got 60 to 70, which was designed for cholera, and that certainly saves lives. But if you drink too much water, you can dilute out your sodium and get severe problems with hyponatremia, and this is seen in anorexia nervosa. Once your potassium starts to fall, you've got to be very concerned about vomiting, hypokalemic, metabolic alkalosis, laxative abuse and diuretics, the 3 causes of a low potassium, high bicarb. So you can do laxative screens on the stools, you can test for thiazide diuretics, ask, there's a Contador, who's that No, the Schlecks. They use the diuretics to mask the anabolic steroids. That's cycling, by the way. Yeah. Look for ischemic hepatitis or starvation hepatitis, and we've talked about blood sugar, and measure your ECG changes. So the high-risk patients are the significant ECG abnormalities, the significant electrolyte abnormalities, active infection due to their immunoglobulin deficiency or translocation of bacteria, and look for signs of heart failure or cardiomegaly. And if the patient has a BMI, we admit these patients to a high dependency unit, or even, and this year we've had 5 go to intensive care at the Royal Melbourne. And I've mentioned about the concept of thiamine and other vitamins. Where are these people cared for? Well, look, we don't in this state have enough special eating disorder unit beds. There are some at Monash Medical Centre, some at the Royal Melbourne. And these high-risk patients who come in with these abnormalities, we admit to our ICU or HDU. The medium-risk patients, we admit to general medical units or a general psychiatric bed, often in the early stage for that first week under general medicine. And one of the things we've been talking about in the state task force is that we have to educate more healthcare professionals and physicians and other things, particularly in our rural centres, how to manage this clinical problem. And whether it's myself or Catherine or others go around and educate people how to safely manage these patients, because this disease there's a high prevalence out in the society, and we're getting more patients coming in with these metabolic disorders that have to be managed carefully. The special eating disorders units, what do they offer above a general psychiatric bed? Well, they can do nasogastric feeding in our CEED. I know that at Royal Brisbane they have a much more aggressive approach to nasogastric feeding, and a colleague, Jeff Cleghorn, who's a gastroenterologist, has this theory. He's not a psychiatrist, but fairly aggressive nutritional therapy improves cognitive function. Now, part of the problem, and we see this as clinicians, acute or chronic zinc deficiency and protein deficiency seriously affects cognition. And I have this experience training patients for home TPN who've got short bowel syndrome, and they come in really malnourished, like an anorexia patient. We spend a month wasting our time trying to educate them how to do home TPN, and it suddenly dawned on me about 20 years ago, it's all the malnutrition that's interfering with cognitive function. And in fact, when you ask them a month down the track after they've been on TPN, they can't remember the first 2 weeks of their admission. And I think severe undernutrition affects cognitive function in patients with anorexia nervosa. It certainly causes a gastroparesis, and you know, a lot of anorexia nervosa patients say they feel full early satiety. We did a study looking at gastric emptying in anorexia nervosa, pre and post a course of domperidone or Motilium, and showed improvement in gastric emptying. So severe starvation delays gastric emptying. And after the prisoner of war patients came out of the camps and started eating, some of them got acute gastric perforation and died because of their delayed gastric emptying, as well as getting acute pulmonary edema from their refeeding syndrome. What else do the units offer? Well, they can do blood tests, they can do frequent observations, they deal better with their behaviour, like their excessive water drinking, absconding exercise. They place restrictions on all of those. They can monitor the ECGs daily in that first critical 7 days. They can give sedation if the patient's particularly pulling out a nasogastric, look after the skin, and obviously have access to acute resuscitation if there was an arrhythmia or something. As far as a person like me, you need someone who's got an interest in anorexia nervosa, has some training in clinical nutrition, works in a collaborative way with the psychiatric team, and you need a dietitian who's skilled in the refeeding programs and familiar with things like nasogastric or even occasionally nasojejunal tubes, because with severe malnutrition, if you feed into the stomach, they start vomiting and you wonder whether they've got delayed gastric emptying. So we can easily pass the tube into the duodenum to feed. Just a little bit about this syndrome I've been talking about. It's basically a metabolic syndrome due to changes in serum concentrations of those electrolytes. And this is a very brief slide, but what it shows, I'm sorry the prints didn't come out here, during starvation, blood insulin levels fall. That's that line there. At this dotted line, we've got carbohydrate refeeding. And what happens with carbohydrate refeeding is you get a hyperinsulinemic response. So your blood insulin levels goes higher than baseline. This line down here is just reflecting ketone bodies, and when you start to glucose refeed, ketone bodies disappear. And what a lot of doctors don't understand is what is the effect of that hyperinsulinemic response to glucose refeeding. Well, this diagram tells you what happens. As we mentioned, in starvation, cells crenate. That's a normal sized cell. That's a cell that shrunk. It's got decreased intracellular water. During starvation, extracellular water increases, so-called kwashiorkor. You see the pictures of Ethiopian children with swollen eyes, edema. That's about 5 days before they die. Once you get that degree of edema with kwashiorkor, you're near death. So even though your serum potassium and phosphate are normal, your intracellular phosphate and potassium are grossly depleted with starvation. And in starvation, as we said, your insulin level falls because there's no glucose around. Suddenly you give glucose and you get this hyperinsulinemic response, and what a high insulin does is suck potassium and phosphate out of the plasma into the cell. And that can be catastrophic and fatal. I've seen a little old lady with rheumatoid arthritis have a serum phosphate of 1, 16 hours after nasogastric feeding with some osmolite, had a phosphate of 0.1 and had a code and a respiratory arrest. And luckily didn't die because we recognised it. So it's the shift in electrolytes driven by insulin that causes the fatalities. And that's why in most anorexia nervosa units now, they know about restricting carbohydrate in refeeding during that first week to prevent the hyperinsulinemic response. So to summarise, malnutrition results in depletion of the intracellular water, potassium and phosphate. Refeeding of glucose causes a hyperinsulinemic response, and this increased insulin results in the shift into the cell of potassium and phosphate. Another thing that a lot of doctors don't understand is that insulin retains salt and water in the distal tubule of the kidney, and this causes refeeding edema. And if you're elderly and you've got heart trouble, refeeding edema can lead to acute pulmonary edema and death. All of your patients in refeeding with anorexia will get a little bit of ankle edema. Their weight goes up initially due to the refeeding edema, then they diarrhea on usually day 5 or 6 and they lose their weight, and that's all water retention. We try and avoid this syndrome by really restricting carbohydrate. So the consequence of the syndrome is hypophosphatemia, hypokalemia, and everything goes down. They can be a little bit insulin resistant and get hyperglycemia if you give too much glucose. Acute micronutrient deficiency, we've talked about giving thiamine prophylactically before you give the glucose, and fluid retention. So recognise the patients at risk, be careful in your nutrient prescription and monitor urine output and body weight as a marker of water retention. What are the consequences of hypophosphatemia? Well, phosphate's a really important element in energy sources of ATP, so it can aggravate heart failure, it can alter CNS function with seizures, delirium, and importantly, once your serum phosphate gets less than 0.5 millimoles per litre, you get 50% reduction in striated muscle contraction strength. So people can't breathe. They can't move. They become paralysed. And also remembering that phosphate's really important for oxygen carriage on 2,3-DPG. So you desaturate. And that's why intensive care units now, to prevent patients getting intubated and desaturating, we give very low glucose, high lipid TPN and enteral solutions. Treacy Care, that was formed about 15 years ago, and we understand now in critical illness and in malnutrition you restrict carbohydrate because of this syndrome. I think you're all familiar with the so-called the Karen Carpenter syndrome, who went into ventricular fibrillation. I think it was after a cheese sandwich in the cupboard and died because of the carbohydrate load, the hypokalemia of VF. So it has other effects, which I'm not going to go into. You've got the notes. The critical one for a low potassium is its effect on the ECG and predisposition to ventricular arrhythmias. And hypomagnesemia, again, arrhythmias and neuromuscular. The so-called tetany. You will never correct someone seizuring with hypocalcemia until you've corrected the hypomagnesemia. It's a trap for young residents. They pump in the calcium and they're still seizuring. You've got to correct the hypomagnesemia to stabilise the neuronal end plate. So what tests do I recommend? Well, this is partly out of the marzipan recommendation as a baseline for blood count, electrolytes, phosphocalcium, magnesium and albumin. And remember our young girl, BMI of 10. All the initial serum potassium and phosphate and magnesium were normal. And luckily we refed her safely and she didn't get that catastrophic fall in those electrolytes because we're aware of the nutrient prescription that was appropriate. We look at trace element deficiencies and we look at the other standard vitamin and water-soluble and fat-soluble vitamins. We always check thyroid function because some of these patients get their hands on thyroxine. It's a mechanism of weight loss. We measure their ECG, we monitor their electrolytes daily, standard liver function, full blood about twice a week, and then other nutrients less frequently. As far as the refeeding syndrome goes, we start low, but we get up to recommended by day 7. And one of the things I said, don't sort of hang it 10 kilocalories per kilogram for 2 weeks because you're scared of the refeeding syndrome. This syndrome occurs and people die with refeeding in that first 3 to 7 days, 3 to 5 days probably. The major electrolyte shifts are occurring quite quickly. So start at about 5 to 10 kilocalories and use an isoosmolar formula like Jevity. Don't use a hyperosmolar 2-to-1 formula that can cause diarrhoea and cause further electrolyte disturbances. Daily monitoring. Sometimes in intensive care we do thrice daily electrolytes in those first 48 hours. We give thiamine, I can't stress thiamine enough. And on about day 3 you can double it, and by about the end of the week you're up to near prescribed calories. So for a 30 kilogram patient, 30 kilocalories per kilogram, you're up near 1,000 calories. And you will gain weight on that. Initially you'll gain a lot of weight, and that's called fluid, although we try and minimise that by doing the slow gradation. And you can give all the micronutrients both in oral and intravenous forms. That's available here in Australia. IV phosphate, potassium phosphate, Sandoz phosphate tablets, you're all familiar with KCl, mag chloride, mag sulfate, IV, and calcium gluconate. So they're all available, and we supplement. And working in anorexia nervosa, these malnourished, they're all on oral Sandoz phosphate tablets. And just with the glucose and fluid retention, look for evidence of heart failure. If you give too much glucose that they can't oxidise, they'll get fatty liver. The fatty liver is due to lipogenesis in the liver of excessive glucose. Obviously, if they become hyperglycemic, you can actually get dehydration and hypotension, and even hyperosmolar non-ketotic coma. And as I mentioned, if you give too much glucose, the only metabolic pathway of non-oxidised glucose is lipogenesis. And the respiratory quotient of that is about 12. So you produce a lot of CO2. So some patients have to be intubated because of the wrong nutritional formula. I would strongly recommend looking at the marzipan. You can download that. Those references are there. There's a good article on refeeding syndrome. And I said I'd stop about now and take some questions. Thank you.
My brief, when I knew there was an adult physician talking, was not to sort of say the same stuff all over. I was just trying to point out some of the difference between the adolescent section looking after young people with eating disorders. So what I thought we always like to have learning objectives in paediatrics, that by the end of this talk you'd have a bit of an understanding of the acute and chronic medical risks in children and adolescents with eating disorders. And I'm going to introduce you to our favourite words, the H words. As a paediatrician, most of my colleagues think, oh my God, why do you look after adolescents? And one of my colleagues thinks that paediatrics is the most fun specialty, and looking after young people with eating disorders is the most difficult part of it. So the reason is that adolescents are fun to work with. They're able to talk to you as opposed to small babies who don't talk to you with words. They're honest, and it's a transitional time with developmental tasks, so they're changing. And what we do in adolescent medicine can have a significant impact in their adult life. So adolescence is something that's been around for a very long time. This is a quote from Socrates, so many thousands of years ago. Of course, eating gluttonously is perhaps not what we're talking about today, but tyrannising their teachers and contradicting their parents, I think that still goes on. And so we get to eating disorders. I'll try and flick through some of this. This is all stuff is bread and butter to you, but it's a psychological disorder with profound physical complications, and the body and mind relationship is very tightly entwined. So what we know is it's a multifactorial disorder with a symptom pattern that leads to a common final pathway, and the medical complications can be serious, irreversible and fatal. Now in my neck of the woods, thankfully fatal is not common, because we see children and young people early in their illness, and even if we see them through the course of their illness, the complications that David was describing, we don't see as often. Sorry, teenagers on the PowerPoint. Okay, so what we kind of think is that 50% of these kids are going to have a really good outcome, which means they recover completely and lead a good life. 25% an intermediate outcome, and 25% do poorly. But the duration of illness is up to 7 years. So you can imagine, as a paediatrician, if you're looking after a 12-year-old, you may look after them for the entire course of their illness, or in fact, if they start at 15 or 16, you may be the front line initially, and then hopefully not handing over to the high-level expertise of the medical specialists, but the GPs and family doctors will be looking after them. Okay. In paediatrics, we see a lot more of this sort of ragbag group, which is actually the biggest group, called eating disorders not otherwise specified. Partly because we're seeing younger and younger children who, with a DSM-4 criteria can't have amenorrhea because they've never actually had a period, or because they're a boy. So it's often like a more partial syndrome with disordered eating. The concerns around body shape may not be so obvious, or it might take a long time for the young person to tell you about, and the patients can be quite young. And there's many more patients in this group than people with a formal diagnosis of anorexia nervosa or bulimia. And we see younger patients, and the prevalence in the literature is somewhere between less than 1% to nearly 15%. So why do you need a sort of medical person, and why might you need a paediatrician when you've got a young person with an eating disorder? So I kind of looked at it thinking about what you might use us for. Is there something else going on? How sick is the patient? And what are the longer term risks for young people? So this is a fancy list of differential diagnosis of eating disorders, which basically a child who's lost weight. Why do children lose weight? And they can lose weight because they've got problems in their guts, they've got problems with their hormones, they've got some long-running or long-standing infection. And we've just had a young person, I think she was about 13. She presented to our emergency department at 11 o'clock at night with a diagnosis of an eating disorder. She'd been sick for about 4 or 5 months, had lost 15 kilos, was very picky and fussy with the food, but had had night sweats and fevers for 3.5 months, and she had endocarditis and had destroyed 3 of the 4 valves in her heart. And it was interesting watching her progress after she went off and had a fancy heart surgery. She still needed to be renourished, but she didn't have any eating disorders behaviours once she became well. malignancies and other psychiatric conditions, such as OCD or just anxiety, are things to think about. But the problem is that eating disorders are common, and food is a treatment for malnutrition, so that the treatment may in fact reveal an eating disorder. And generally doctors have a much bigger worry that they're going to miss something rare and unusual. They're going to miss the inflammatory bowel disease, or oh my God, the child's got a brain tumour or endocarditis. Well, really most of the time they're missing the thing that's right in front of their face, is that this child isn't eating, or isn't eating enough food, or is mad, crazy exercising, and that's why they're sick. And in fact, for some very compliant, sweet children who will deny any symptom that might be related to eating, once you start feeding them, all their eating disorder behaviour becomes really overt and obvious. So these are the words that these are the mantra at Monash Medical Centre about health. What we want for these young people who are facing this very difficult illness at an awful time of their life. No teenager wants to be sick. It is the most boring thing to have to be coming to medical appointments and seeing psychiatrists when you're meant to be, you know, figuring out who you are and what you want to do with your life. So we want, at the end of their illness, for them to have these areas of health addressed and hopefully mediated when they get well. So the things that we are interested in are their growth, so their height, that their heart is okay. I couldn't think of any way of describing their bones besides happy bones. That their hormones work, and that their heads are doing okay. So the CDC is this august organisation that produced growth charts, or the people who are organised growth charts internationally. And I'm just going to spend a little bit of time talking about growth and BMI and stuff, because this is what's so different from adults. So if you're a 25-year-old woman who's had a normal adolescence, grown to your normal adult height, and now you have an eating disorder and your BMI is 10, that's quite different from if you're an 11-year-old boy who hasn't gone through puberty. So growth charts show your height for age and your weight for age. This is the CDC one. Of course, growth charts is about a 3-week lecture on which ones are used and how you use them. But basically, the general principles is everything goes in one direction until you finish growing. It goes up. And the other thing is, we know it's not just about the weight or about the height. And there are all this stuff in the literature about BMIs and IBWs and ideal body weights. I don't know what WTF stands for. So what is a BMI? What is a BMI, and what does it mean? So I'm sure you're all familiar with this definition, which is the weight over the height metres squared. It's a screening tool. It's not a diagnostic tool. And for children, BMI is age and gender specific. So you have to look at the age and gender specific charts. You can't just go on adult BMI, normal BMI's range of 18 to 25 or whatever, or obesity is over 35. You have to actually look and see. So this is the age-specific BMI chart for girls, 2 to 20. And interestingly, well, I think it's interesting, we call this bit here, when you're a kind of preschooler, you've gone from being a toddler to being a preschooler. It's known as the adiposity rebound. Isn't that beautiful? The adiposity rebound. Basically, if you've got children of your own, you probably remember they might have been little chubbers when they were little, 1 to 2. They get up, start doing stuff, go to kindergarten, and they kind of stretch out. But the adiposity rebound is followed by your BMI going up over the course of your teenage years, or your primary to teenage years. So for children, BMI changes with age, and mostly children stay on their line. So this child is on the 95th centile here, but over time, this boy has grown normally. We might be a bit concerned as paediatricians if you're on the 95th centile, but his BMI hasn't changed in an abnormal way. So the CDC, with the growing obesity epidemic, have really good charts about BMI tables for children and adolescents. And why do we have these BMI tables and charts? It's because we're not very good at figuring out whether kids are too fat or too thin. So I'm going to show you a couple of slides to see if anybody can see the risk. So just in general, what do people think? Too thin, too fat? About right, this girl's 4. And I know that you're not all paediatricians, but let me tell you, paediatricians don't get this right either. Okay, so she's thin. She's normal, but she's thin. She's on the 10th centile. Okay? So this girl, too thin, too fat? Who knows? She's 4, they're both 4. She's at the other end. She's still normal, but 10th centile and just over 90th centile are both the same variation from the middle. So when we look at children, we are notoriously bad at being able to judge whether they are, their BMI is appropriate for their age and stage. The other thing is that accurate measurements are critical. In my maths career, which ended in VCE, I kind of generally got the concept that if you divide and it's squared underneath, that bit underneath is the important bit. So if you get the height wrong, you can make the BMI look much worse or much better than it really is. So accurately measuring the height is really important. And see how this child's BMI has changed with just an inaccurate measurement of the height change. Okay? So often this is not the kind of young person that we see, and you need to have good measurements, and you need to have some measurements over time to help you understand where this young person's going. And this is my picture that David has. You see thin, I see fat. And as you can imagine, from if you know anything about what children's drawings are, this drawing has been done by quite a young child. Okay, so I'm just skipping through this sort of stuff. The history and the risk factors, something probably none of you would do in your adult world is look at the baby book. Most of you in your personal world, if you have children, will have trotted off to the Maternal and Child Health Centre, and there are all these beautiful growth charts that are available for what was happening when you were little, when you were being supplied with nutrition by someone else and you didn't have any choice about whether to eat it or not. So actually knowing about the child's previous growth is really important, previous weights. With children, it is also important to ask those specific eating disorders questions, which you are all familiar with. You may not be familiar with the HEAD screen. Everybody know what that is, or want me to say what it stands for? Yep. So it stands for, it's basically looking at all of the things in adolescence that are important to your health. So home, education, attitude to alcohol, and activities. D is for drugs, S is for sex, and the second S is for suicide. So when we're assessing a young person, we don't just look at what they're eating and what they're doing, but we look at all of these things in their life as well. Then we look at symptoms that David was describing. Are they feeling dizzy when they stand up? Are their guts slowed down? All those kind of things. And the risk factors that you're probably aware of, if there's a positive family history, so the obstetrician was saying she has young women who are having babies who have eating disorders themselves. Their babies, when they grow up, are more risk. Kids who are involved in visual sports like gymnastics or ballet are at higher risk. And we see this sort of personality traits of kids who are very high achieving, very obsessive, want to do everything right, really perfectionists. And conversely, they often have quite low self-esteem. In a paediatric world, we always think about physical or sexual abuse. In the adult world, I believe that with bulimia, that's probably a more common thing. But, and of course, dieting. Now, 85% of 15-year-old girls are on a diet. Not all of them get eating disorders, but as an entry point to an eating disorder, dieting is often a risk factor. So in terms of a medical physical assessment, every organ system can be affected. And you need to look at all these things, appearance, the vital signs, so that's the blood pressure, heart rate, the skin, the heart, the tummy, and their hands. I've had young people presenting to me who have eating disorders, and they're presenting because they've got chilblains. So they've been sent along to me because they've got chilblains, and nobody seems to have noticed that they weigh 22 kilos and that they don't eat. It's astounding. The other thing is that adolescents with an eating disorder may be deceptively appear quite well. They can present without the typical features and without the really overt behaviours, and you need to assess them in all directions. You can't just go on one single assessment to understand what risk there is. So the other really important thing is weight gain is normal in childhood. So if the child has lost weight, that's really abnormal. And if the child isn't gaining weight, that's also abnormal. So if your child still fits into her size 8 clothes from when she was 8 years old and she's 14 years old, that's not normal. The other important thing is to think about percentage body weight. So that if you're a 30 kilo child, 10% of your body weight is 3 kilos. If you've lost 6 kilos, that's a large percentage of your body weight. Whereas, say, if I lost 6 kilos, it wouldn't be quite such a large percentage of my body weight. The other thing we're seeing more and more frequently is this rapid weight loss from an overweight to a normal weight range. So the young person has a normal BMI, even if you've looked on the fancy charts and it's age appropriate, but they've come from an abnormally high BMI, sometimes obese, sometimes just 90th centile, or they've grown along that centile all their life and now they've dropped down to the 50th centile. And people are congratulating them and thinking they're looking fabulous, but really they're really, really sick. So remember the growth chart. Everything only goes in one direction. So if you're a child or a teenager and your weight is going down, something's going on. And it's usually not all that other fancy stuff, celiac disease or maybe celiac disease. And the other problem is that sometimes people do have 2 diagnoses. So we have a group of teenagers with diabetes and eating disorders, or diabetes and celiac disease and eating disorders. So you do kind of need to think about it, but often people don't understand that fundamental thing, that the weight and the height only goes in one direction in normal growth and normal children. So in terms of looking at BMI, you need to be where the normal BMI, because the child hasn't grown. So they haven't gained weight, they haven't grown, but their BMI stayed normal. So that's not normal, because your BMI is meant to continue to grow up. This concept of percentage median BMI comes from Junior Marzipan, which is a document released, I think, this year or last year from the same people who did Marzipan, who must have a sick, twisted sense of humour because Marzipan's very fattening. But they love this percentage median BMI business. So basically the concept of that is, if you look on the 50th centile, okay, that's the median BMI. So you look at where your kid is, say she's 15 and her BMI's here at 14, then you have to do percentage-wise, oops, I'm not very good with this, 15 there, and then the normal 50th centile is 20. You do the maths on that, and if they're less than 70% of what the median BMI is, that's a marker of severity or risk. Of course, that doesn't really help you if your BMI used to be up here and now it's here. You've had the same percentage change, but it's got nothing to do with median BMI. In fact, your median BMI will still be higher than other people your age. So no one thing helps you with the assessment. You have to have all of the information. So what happens with your heart? So basically the concept, and I think David explained a lot of the stuff about starvation very elegantly, but basically your whole body slows down when you starve. Your poor little hearts are trying to beat really slowly, so they're not using that much energy. And children have higher heart rates than adults. Again, with children, heart rate and blood pressure depend on age and gender. So, for example, blood pressure depends on if you're a boy or a girl, but also how tall you are. So you need to have specific charts to understand which blood pressure is normal for this child. But basically, we would think you need urgent medical assessment if your heart rate when you're awake is 50 and if there's a postural change of more than 30. And similarly, if your blood pressure drops by more than 20 or if you're symptomatic with fainting. The ECG and biochemical changes affect your heart. Some kids have irregular heart rhythms, and you've probably all seen children with cold blue hands from their poor perfusion. The other thing to think about when you're assessing risk and medical risk is about their behaviour. So we have young people who come in for medical care because of behavioural concerns. So they go on strike. Sometimes they go on strike because it's all just too hard. They know that they're going to have to come into hospital, so they might as well starve themselves really effectively for the next 4 or 5 days. That's a very confronting thing for families to manage. So often they'll come in for medical care. If they are crazy mad with their exercise, you know, getting up at 2 o'clock in the morning to run around the streets of Newtown while they've put a pillow in their bed so their mother thinks they're asleep. Or if they're violent towards their parents in the trying to refeed at home stage. Sometimes those kind of behaviours are too overwhelming for families and they need some support. And then behavioural risks that are more psychiatric, obviously, the self-harm or suicidal ones. So in terms of complications of the anorexia or of an eating disorder, I'm just going to click through this. The short-term complications are exactly the same. The physiology is exactly the same. The bloating and abdominal discomfort. It's really interesting about the cognitive changes. We've had kids do their VCE French or maths exam, get 99.95%, whilst they can't eat a banana. So they're in hospital doing their VCE exams. So it's a very interesting thing what goes on in your brain. Clearly, if you're really malnourished and you're doing very badly, you have poor concentration. But it's intriguing to me that you can perform some things very well academically, yet not do something as basic as feed yourself. And I'm not going to go over refeeding and cardiac failure. So in our inpatient medical care, basically we monitor. So we monitor heart rates, blood pressure, temperature, and the electrolytes and stuff. We get our patients to rest, so they need to rest on their beds. We support meals and have a meal plan, which is a gradually increasing amount of nourishment. And in our service over at Monash, we hardly ever use nasogastric feeding, so that most of our young people are refed with food or with some supplements like Ensure or Pediasure. That varies across Australia what people do, and we have the same rate of weight gain and the same length of stay in hospital, and we think that it's more normal to eat food than to drink goop or have someone put a tube down you. So that's why we do it like that there at our service. Now, are we doing a lot of it? Yes. So they stay. This is just a little chart showing that kids stay about 2 weeks in hospital when they've got these medical complications. That's been pretty standard. This is up till July. So, but our number of patients, sadly, if we extrapolate, this is only July, is going up. Now, we don't want any adolescent patients with eating disorders to be in hospital. We want them to get in their care in the community. We want them to be safe. So, you know, we're just looking for work, got nothing else to do, let's just admit all these patients because it's all too hard at home. No, because these are the patients requiring cardiac monitoring. Now, we only monitor their heart rates if they've got a heart rate under 50 when they're awake, because we know that when they're asleep, their heart rate will be 32. So not everybody who comes to hospital for medical care gets their heart rate monitored. And, but this is what's happening. And there's been an explosion this year. This is only till July. So in 2006, when, not long after I started, it was really rare to monitor somebody's heart rate. Really rare. And it's getting more and more common. So these young kids are sick and they need medical care. And our big message is we want people to realise they're sick before they need medical care. We don't want them in hospital. So that's the acute medical stuff. The refeeding stuff happens. We do the same kind of thing. So if I was interested, we don't use thiamine, but we certainly love vitamin D and we love phosphate. So, and I think we don't use thiamine because in the paediatric literature it hasn't really been a problem. Okay, so the chronic medical risks are about their hormones, their height, the bones and their brains, not heads as in the head screen. So in the outpatient care, where we want all our patients to be, this is why having a doctor is helpful, to monitor for long-term complications of their amenorrhea, are they going to puberty, what's happening with their bones, and are they growing? So this slide's courtesy of my colleague, who's an endocrinologist, paediatrician. So I'm sure you're all very familiar with the hypothalamic pituitary axes, of which there are at least 3. But eating disorders affect all parts of your endocrine system. Now, just reminding people what this HPA thing is. Basically, in the middle of your brain, you've got your hypothalamus, which sends signals to your pituitary, which sends signals to your other glands. This is describing the HPA adrenal axis, but basically then it's a feedback loop. Now, there'll be a test at the end. I expect you all to remember all of these things, but this is how complicated it is about what happens when you starve. All these things get switched on or changed. All these different pathways get changed. And the bottom line is you get a sick thyroid, your puberty doesn't work, you switch off your periods if you started having them, and you stuff up your bones. And so it's complex and it's a sort of feedback loop. So just on the period business, because we do see, quite a lot of young girls who've started menstruating and then they get their eating disorder, then they stop. So what happens is that in that feedback loop we're talking about, the changes in these hormones, which are to do with fat, change your signalling hormones, change your estrogen testosterone mix, and lead to you switching off your period cycling. Now, we've had one pregnancy in Monash in the last 10 years, someone who we would have thought couldn't get pregnant apart from the fact she was having sex. But so you can still be fertile even though you're not having periods. So what happens about this? We know that you get your periods back if you recover weight. It's not just about weight, and this work shows in a complex kind of way. It's about percentage body fat, and it's about BMI, and it's about that most kids will get their, there's sort of this crossover bit. So most kids will get their, girls will get their periods back when their percentage body fat's over 20%. And similarly on this, change in fat mass, you can see that there's a sort of crossover group as well. And that sets your periods going again. And it's a really good sign of health because it's a very finely tuned system. So we often will have kids, we're trying to figure out where we're going to go with where they need to get with their weight, get to a weight we think is going to be where they'll get their periods back, and then nothing happens for a while. So what we do is we watch over a period of time, say 6 to 12 months. Nobody seems to remember how much they weighed when they got their periods. Sometimes they know. I was 40 kilos when I was in grade 7, I got my periods, or mostly people don't know. But we sort of try and get them to an area we think they'll come back to. We let them go, maintained in that weight for a certain period of time, and then we review it because we know that the cycling hormones are good for your bones. So paediatricians love growing. That's what we're helping kids to grow. So it's very, very disappointing if you have a young person who gets an eating disorder before their puberty starts and they are so unwell during that critical period of their life that they don't grow. So I've got a few little girls who started at 12 and are still the same height they were when they were 12. It's really depressing. Puberty will eventually kick in even if you haven't grown, and your bones will fuse and you will have no option. You will never grow anymore. Once your bones are fused, that's it. So that's what bone age is about. Is everybody familiar with bone age? Basically, it's a series of x-rays and you match up the bones in your wrist against the age-matched x-ray, and it helps you to say, yes, you've still got some growth potential, or no, it's all over, red rover for you. You're going to be 150 centimetres the rest of your life. Not that there's anything wrong with short people. It's just not so good if you're short because you couldn't feed yourself for 5 years when you're a teenager. So we like happy bones. The other thing that's really going on with your bones when you're an adolescent is that this is a critical time for your bone bank. So your bones are growing and you're putting calcium into your bones to get strong bones. And this is it for the rest of your life, through your 17 pregnancies, when you're well, whatever. When you're a little old lady, what you did when you were between 12 and 18 is the crucial part. And sadly, it's potentially irreversible. And again, it's very depressing to have someone recover from their eating disorder and then have thin, weak bones so that when they're running in the fun run to raise money for the Children's Hospital, they fracture their hip or their sacrum, or it's very depressing. So it affects skeletal health across life, and that's why we're really interested in it and we monitor it. There is an increased risk of pathological fractures, and certainly some of the young people who have a sort of athletica type of anorexic picture can develop stress fractures in their feet, stress fractures in their backs, stress fractures in their hips. So, and it's not to do with one single thing. It's not just vitamin D. It's not just calcium. Your bones need nourishment to grow. A DEXA scan, some of your patients may have had them. This is actually an adult DEXA scan, but it gives you the sort of general gist of the thing. In children, when you're growing in puberty, the thing that's the bones that are growing the most are your spine. It's not like suddenly your legs and arms grow faster. Your legs and arms keep growing, but your spine, your height comes through your spine. So we're really interested in spines. And again, there's a sort of healthy zone between 0 and 1 and +1 and -1. And this person, excellent healthy person, but really old, way outside of my range. But we see kids whose bone density in their spine drops down during the course of their illness. And we're also interested in hips, because that's the other area that is most at risk. So it's about the type of bone and about the fact that the spine is growing during puberty, that's what's most vulnerable. Now, brains and teenagers, if anybody's got a teenager of their own at home, will understand that what's going on in their brains is something that's still evolving. So just like children are growing physically, and all of these other things are happening, the things that are going on in their brains during the adolescent years are really important. So what happens effectively, this blue stuff is showing what's happening with the maturity of the brain, and you're losing grey matter as you get older. So when you're a baby, you come out and you've got hundreds and millions of neurons, and the first 3 years of your life is spent pruning down those neurons and creating your pathways. But that process actually keeps going, we think, up until around 25. So that's why adolescents are risk takers and think they're invincible and got no idea. It's also why they're at more risk of developing addictions and having the onset of a mental illness. But if you're not nourishing your bones or your brain, what happens to you? So we know that in anorexia, there's volume deficits in the white and grey matter. When we scan the brains, we know there's functional change when they do fancy functional assays of the brain. The fact that the hormone axis has been screwed up also affects your brains. Now, we haven't figured all this out yet, but we do think that brains need sex steroids. So if you switched off your sex steroids for a few years while your brain was in this important developmental stage, it's probably not good for you. We also know that with weight recovery, that the white matter recovers, but we don't think the grey matter recovers, and that's an ongoing area of interest in research. Just to sort of flag to you why we want you to understand about the medical risks, not just the short-term acute stuff, but the longer-term for adolescents and children, is that we're seeing more and more new patients. So this is our data from Monash, and as you can see here, this is the new patients up until July. So we're being inundated with sick children with eating disorders, and the potential outcome for them is that they will do overall well, but it's coming at a crucial time in their lives where they'll have long-term sequelae. And it's a terrible thing to think that the adult physicians and adult community will be looking after people with the complications of their childhood illness. One thing to say is that over time, eating disorders have a higher rate of death than childhood leukemia. And the response of that most families experience when their child has an eating disorder is quite different from when your child has leukemia. So it's a really important area of medicine, and just want you to remember the things that as paediatricians are interested in: their height, their hearts, their happy bones, their hormones, and their heads. And these are the references. Junior Marzipan is a really good document. Pediatrics is the American resource, and the NICE guidelines come from England as well. Thanks.
I was just wondering what you're saying about the SAS test, and that requires a person to get rubbed down and get back up again without using their hands. So what about people who over-exercise as their major form of, they might restrict but over-exercise extremely? Will they get to a point within their BMI is at a certain point where they're
I think once you start doing a BMI of below 12, even this group of over-exercise really struggle with that, and it's possibly related, not only just reduced muscle mass, some of these people also are very vitamin D deficient. And vitamin D deficiency, everyone thinks is just for bones. I disagree with that. Vitamin D is critically important for muscle function. And in the elderly, we give vitamin D so that everyone thinks so they don't break their hips. The reason I give it is so they get muscle strength, so they don't fall when they break their hips. So vitamin D, and a lot of these I didn't actually mention, well, I quickly mentioned fat-soluble vitamins. Vitamin D is critical. There is a cut point where these people become really asthenic and weak when they're in that high-risk group with BMIs less than 12. Yeah. Yes, up the back.
Two questions. So the first one, thank you, great talk.
Oh.
The first one, so prophylaxis. So someone comes in who may be moderately starvation.
Excuse me, do you mind speaking up kind of
Someone comes in with maybe moderate BMI, 14 or something.
Yeah.
You do all your tests, but some units start people automatically on things. Obviously, you're saying firemen.
Yep.
Anything else?
Well, look,
you
yeah,
routinely
because you
start
can often,
magnesium
what I was
or-
saying is you can often be misled by normal potassiums and normal phosphates and normal magnesiums. The total body stores of those elements are grossly reduced, and hopefully if they're actually in, where we're trying to supervise their meals a bit better and they're going to actually consume more calories than they would be if they're home, because that's why they're in, they probably have a target discharge weight. We give it prophylactically. We still monitor it, but we don't wait for the phosphate to drop to 0.3. Oh, we've got to give them some phosphate Sandoz tablets. So anything exogenous you give will start to replete the depleted stores. Your car still runs when the flashing light on your petrol's on, but it's better to run your car with a bit more petrol than reserve. That's the analogy I use in this. Do you understand what I'm saying?
Yeah, so you're giving phosphate.
Phosphate, Sandoz phosphate tablets, 1 tablet BD. You can easily give Slow K or Chlorvescent. It's easy to give Magman.
Yeah.
Give them because they'll replete their stores.
Yeah. Okay.
A bit of safety with the tank a bit fuller. So if you've got to go on a long journey, you're not going to... Because all these people don't stay in hospital all the time, and you just don't want them then deteriorating and drop. People drop dead of this disease. They drop dead of arrhythmias.
Second question. Did I hear you say you'd be checking the glucose half an hour before each meal?
No, I didn't say that.
Oh,
No,
right.
no. No, but I'd be checking. I mean, it's very easy to do BSLs. You've got to be careful with BSLs if they've got really low cardiac output. It's not accurate. So if someone's in a critical situation, we're tackling the venous blood rather than just a fingertip BSL. But that's if they're being monitored. We're doing their electrolytes twice or thrice a day with blood sugars. Yep.
Two questions. The first one is you talked a lot about the ketosis and to monitor the urine. Is dipstick adequate? Or
Yes. Look, you can calibrate your BSL machine. We measure serum ketones just in ED on your blood sugar machine. They can measure ketone levels. And we do that only in diabetic ketoacidosis. Urine tests are fine for ketosis. As a test. That's fine.
And the second question was,
You can look at their bicarb too. If you've got a metabolic acidosis, your bicarb will be like less than 25.
Yeah, I noticed that anorexic girl had bicarb was 24.
It gets a little bit more complicated. The metabolic acidosis will pull your bicarb down, but if you start vomiting, your bicarb goes up. That's called a hypokalemic metabolic alkalosis. So sometimes it can be normal. But if you've got profound acidosis from ketosis and starvation, your bicarb should be low. Correct.
The second question was in regards to the repeat eating syndrome. You mentioned that what drives it is the hyperinsulinemia.
Essentially, it's a metabolic, as the first slide said, that Solomon's paper published in Japan, it is a metabolic syndrome related to excessive glucose refeeding.
Do you try and tackle it from the insulin level and try to...
No, they're not insulin deficient, these people.
No.
It's their pancreas's response to a glucose load.
Yeah, but it's driving the problem.
It drives the problem, so you minimise the stimulation to the pancreas by reducing the oral glucose or nasogastric glucose to blunt the insulin secretion. Yep.
Can I just ask a
about, we have the situation sometimes where they're referred, I'm a dietitian, they'll be referred to us as an outpatient
Yep.
with very low BMI,
Yep.
and you're quite hesitant about feeding because you can't get the regular blood tests done. Every now and then we'll contact the doctor and suggest admission in order to refeed.
Yep.
Do you have advice around what you might do about that?
To be honest with you, I don't get involved with that because usually the family or the patients or the GPs are ringing the psychiatrist. I'm the physician and I only get to see the patients that are actually in hospital. So I don't go to psych outpatients and see patients like you're talking about. So I can't really... So you're trying to give nutrient supplements and electrolytes and vitamins and phosphate to the outpatients?
I'm from a rural area.
Yeah,
So
sure.
you'll get someone referred to you by a local GP who's got a BMI of 13.5, 14, and they'll want you to give them dietary advice. And the cut-off point where you go, actually, this is not safe in the community.
Yeah, well, it's right on the edge, isn't it? 13.5 is where Marzipan says it's the lower limit for medium risk. Once it's under 13.5, they define it as high risk. And I think high risk, so if someone comes in with a BMI of 12, they should be in hospital. That's what the Marzipan got, yes.
Just back to what you were saying about vitamin D. Do you have a different threshold for supplementing covering vitamin D, or is it just based on osteoporosis?
Well, I'm using a lot more of the 50,000 unit single capsule, so I get it up quickly. Compounding pharmacies in Melbourne will now dispense the 50,000 unit capsule. Ostolin and Osteovit has 1,000 units. Now you can swallow 50 of them if you like. I don't think anorexia is right. We'll swallow 50 capsules. So there is a 50,000 unit capsule, and there's no danger in going from 25 to 60 quickly. Vitamin D is flavour of the month now. You talk to Spiros Falanis about the pathogenesis of type 2 diabetes. It's the cyclic AMP of the 2000s now. When I was a medical student, everything was explained on cyclic AMP. But even cancer now. Trevor Kilpatrick's work on multiple sclerosis. Why does Tasmania have 5 times the incidence of MS than Queensland? Well, their vitamin Ds are about a quarter of the Queenslanders, and now they're doing research in Tasmanian adolescents trying to prevent MS by giving vitamin D. You might be familiar with that work. Sorry, I've been walking around and the cameraman's asleep. I can't stand still. Yes?
When you can supplement their calcium often and phosphate, I wondered about using calcium carbonate versus calcium phosphate and then therefore using it covered for both.
Well, you can do that.
Yeah,
that's fine.
rather than saying it's...
Yeah, intravenously I use potassium phosphate. You can get phosphate ions, 13.4 millimoles in 1 ampule, or you can get 10 millimole K phosphate as an intravenous, and so I use K phosphate because they need both. Yep.
I'm an obstetrician. Have you seen any clients with... Sorry, I'm here.
I just got a bit of a surprise. Obstetrician, yeah.
With pregnant women with eating disorders.
Yeah, no, I've never had the pleasure of being involved with seeing an anorexic deliver a baby, because I thought most of them were amenorrheic.
The binges and purges.
So the bulimic ones will get, but the nervosa ones, and Catherine's going to talk about this, is,
but hyperemesis without an eating disorder coming in vomiting for 3 weeks, is a generalist obstetrician going to be safe looking after their refeeding, or should we be consulting?
Well, we liaise with the Royal Women's. I've taken one patient in my career on home TPN with hyperemesis right through a pregnancy. I've taken one home TPN patient through a pregnancy, which was a challenge to work out the nutrient prescriptions to grow the baby. Look, I've got a patient at the moment, 26 weeks. She's probably got an idiopathic gastroparesis, and we're doing nasojejunal feeding on her, which is helping. I'm just reluctant, TPN in pregnancy, the big worry I have is Lyme sepsis, because if you get a septicemic illness, you'll lose the pregnancy. Now, I would rather do 3 or 4 nasojejunal tubes under a bit of propofol and feed them enterally, because you don't get infection or septicemia with a nasogastric or a nasojejunal tube. I'm not quite... it's interesting you asked that. Would a nasojejunal tube work in hyperemesis gravitarum? I don't know. Is it just a gastric dysfunction, or is it a pan-intestinal dysfunction. I don't know. But certainly in this young girl we've got at the moment, we've got her for 32 weeks and I've had her going for 12 weeks now on nasojejunal feeding with an idiopathic gastroparesis. But the answer to your question is yes. I think they are at risk of refeeding. If literally for months they've had depleted. And the other thing is to check things like zinc and things like that. Zinc is my favourite element. Only because of some work Deanna Reid did in Adelaide looking at vegan vegetarians and then doing neuropsychological testing on the children, showing delayed development in the pregnancies of vegans. Zinc is critical for neuronal development in the first trimester and beyond. And that's a really important study for me. And the mechanism of vegans becoming zinc deficient is their high phytate. If you take a lot of fibre in your diet, you block the absorption of calcium, zinc and copper. That's why we use zinc to treat Wilson's disease, to block copper absorption. That's why in America they use zinc for sickling disease, to block calcium absorption. And high fibre intake, 45 grams, so a lot of the predicants are on 45 grams, get zinc deficient because they can't absorb the zinc because the phytates block the receptor. And then the kids get zinc deficient in pregnancy. So everyone takes their folate 9, but vegans, I tell all my vegans, you must take zinc during your pregnancy and to reduce your fibre intake. That's got nothing to do with anorexia. But it's interesting physiology of absorption.
Any more questions? Last chance. Well, we might as well check question time generally, because I think you're able to stay to the end now, is that right?
I can stay, yeah, I've got a water round at 11, so I'll stay and listen to Catherine.
Okay,
Just wondering about both introduce and David about probiotics and whether there's a role in the feeding syndrome management.
I'd say I don't think I've seen any research about probiotics and refeeding syndrome in adolescents, but David might have more to tell you.
I think I chaired the first probiotics symposium about 10 years ago in Melbourne. It came with a great rush. The company marketed curing HIV, curing rheumatoid arthritis, curing cancer. In gastroenterology, there are 3 indications for probiotics. There is some evidence that they work to prevent travellers' diarrhoea. In Desert Storm, George Bush won, the American GIs did a study, placebo versus ciproxin versus probiotics. Probiotics were better than placebo to prevent travellers' diarrhoea, but not as good as Cipro. So some people take probiotics to prevent travellers' diarrhoea. Secondly, in left-sided colitis with VSL number 3, there's some data that it's good in inflammatory bowel disease. Thirdly, in pouchitis, and people have had a ileoanal pouch. We have problems with recurrent pouchitis, and probiotics have been shown to be better than placebo. But the data on conditions like irritable bowel, we've even tried them in the intensive care setting, putting, your grandfather said, put yogurt down the nasogastric in critical illness, you wouldn't get pneumonia. That's actually, and this is on the whole translocation theory, putting good bacteria in. So we've done some studies on that, it didn't work. So I think there are very limited use. A lot of people take them for IBS. It's a big placebo. If you look at controlled studies in irritable bowel, placebo has about a 40% effect. So it's a very suggestible disease for treatment. I have read nothing about probiotics in anorexia.
Yes. I've got 2 questions. My first one is, once a sufferer weight restores, how long does it usually take for them to get their period back?
Somewhere between 6 to 12 months, and that's really only if being able to maintain in the healthy zone. And so what I would say to the young person is, this is where we think your body will be able to be completely healthy and periods will be restored. We'll give it a period of time. If there's no action, then we will do some investigations. So we look at hormone levels and we look at ovaries on ultrasound, an abdominal ultrasound, so that we can see if the ovaries are looking like they're ready to kick in again. So often we'll see what looks like polycystic ovaries because there's lots and lots of little cysts developing. It's often a good sign that it's going to happen. You know, even if they're physically recovered, often these young people are still doing a lot of work to manage their mental torment. So the concept that they might need to gain a little bit more weight in order for the periods to come back, that's quite challenging sometimes. So we lay out a plan for them. And it depends how old you are, whether you're 13 or 16. And like I say, nobody seems to remember how much they weighed when they first got their periods, but presume that would be a bit of an indicator that you were safe. Yeah.
And also, you must get a lot of questions from parents about a target weight.
Ooh, the target weight. That's the WTF, I think. Yeah. And paediatricians hate it because, remember, it all goes one direction. So it's not like you're a 25-year-old woman who's going to restore to your natural weight that you were when you were 22 before you got sick. So we kind of chunk it down for them by saying, well, this is what you need to do to restore to where you were. But then in that period of restoring, you should have been putting on weight anyway. So you still need to, we need to keep it moving on. And how you manage weight and what you talk about weight and everything, we try and talk about health, and we talk about the young people are often terribly worried that we're going to just fatten them right up again. And the other real concern is for those people who've come from a very high weight, that they think that that's what we're going to insist they need to be. So we talk about health and say that, what is a good weight for you is the weight where you've got healthy bones and your hormones are working. You might not be happy in yourself yet, but that's where you need to be. When we do the DEXs, we do get a percentage body fat, so that will kind of help you as well, a little bit where you are. But it's not, I think this whole thing about you have to be a BMI of this is nonsense, because as you can see for children it changes over time, and where you were, we expect you would mostly go along your line. That's what most children do, or most young people do. Someone had a question over here?
Just I guess more in your opinion, and being in the more acute setting, I come from the community. What do you feel are the reasons why there are more eating disorders being admitted, and what is the reason out in the community that we're concerned for?
Well, we've got some theories. I don't think we've got any facts about why. I think it's still not recognised early. And I was just speaking to Claire, in my private practice in the last month, I've had 2 kids come to me and incidentally tell me, they've waited a couple of weeks to see me, oh yeah, when the GP took my my heart rate, it was 32, or it was 36. I'm like, oh, was it really? Okay, because to me it's so abnormal. It's so abnormal that why wouldn't it be really abnormal to a GP? I figure I'm the specialist and I know, that's really abnormal. So I think it's not recognised. I think often children will present with more gastrointestinal symptoms sometimes. They might not present with overt eating disorder stuff. Their parents don't know what they're doing. It's a very confronting thought that your child can't feed themselves. It's it's not denial, but it's very confronting for families. And when I was talking about the child who was still in the size 8 clothes at 14, well, she was in the size 8 clothes when she was 6. She was a little rounder kind of girl. And she was rounder and rounder, and then stuff happened to the family and the parents were nobody kind of really noticed that she was still, it's like, how can you not notice? Don't you buy clothes every season? Or, because your children grow. That's what happens. You have to buy new jeans because their legs get longer. And so I think it's often not recognised. And what we want people to understand is that it needs to be recognised early so they don't have to come to hospital. Hospital is not the place to treat young people with eating disorders. We really don't want them to come. I want to be redundant. I want to be looking at little babies who do other stuff rather than teenagers and their parents who are struggling with this awful disease. Yeah.
I'm not a medico, but one of the things I'm interested in hearing your thoughts about is the role of OCP in malnutrition and things like that.
Role of OCD?
The contraceptive pill.
Contraceptive pill. So the research shows that it's nutrition that helps restore menses, not giving estrogen. There, I think, is one endocrinologist in Melbourne who gives girls with anorexia the estrogen replacement patches. The research doesn't support it. Artificial estrogen doesn't do anything when you've got no building blocks for your bones. So you haven't got any protein or carbohydrate. It doesn't matter how much vitamin D and calcium and estrogen you've got because there's nothing to heal. So, but on the other hand, if in fact you're a feisty young person with an eating disorder who's going out having sex with a whole lot of boys, the OCP is a good idea. So, you know, you need to be, it's not a one-off, you know, we never give it. It's more about how do we help, and we have those conversations. That's why I put the head screen up, because we've got to remember these young people, while they're fighting this horrible illness, they're still young people who are developing, and they get stuck. Their eating disorder gets them stuck in this really sort of infantile kind of way in some ways, because their parents are feeding them. It's like feeding a newborn baby. It's awful for them. So you've got to engage them in other areas as a teenager, you know. Like, I even know who Lady Gaga is. You know, like, I'm so cutting edge. And they, you know, they really respond. The other thing I should have in the H word is humorless. Eating disorders are humorless illnesses. Everybody's weak. It's also terrible and dark. You've got to move on from that. You've got to see them as a whole person. They might be a very sick little person, but they're a person first.